I am Dr. Pooja Vyas, and my topic is cardiac ventriculography. Though nowadays recent modern modalities are available like cardiac MRI, then CT angiography and 3D echocardiography, they have almost replaced cardiac ventriculography as a diagnostic modality, but still it has some very important role in diagnosis as well as during cardiac interventions. So ventriculography is used to define the anatomy and function of the ventricles and related structures in patients with congenital heart disease, coronary heart disease, valvular heart disease and myopathic heart disease. So ventriculography can be done either left ventriculography or right ventriculography. Left ventriculography is useful in providing information about global and segmental left ventricular function in mitral valve assessment of mitral valve regurgitation, then presence, location and severity of ventricular septal defect in hypertrophic cardiomyopathy, and even it can diagnose left ventricular mural thrombus. And right ventriculography provides valuable information about function of the right ventricular function, global and segmental heart function, and also helpful in congenital heart diseases like in tetralogy of Fallot, and when we want to evaluate pulmonary arteries, then RV outflow tract and as well as RV inflow tract, and helpful in arrhythmogenic right ventricular dysplasia. Injection catheters used for ventriculography there are various injection catheters are available, and to achieve adequate opacification of the ventricles, it is very important to deliver a large amount of contrast media in the relatively short time. So this is image of the various ventriculographic catheters available in the market. We can start from the top clockwise. The first one on the top is PIC catheter by Cook company. Then next is Jensini catheter. Then after that is closed end NIH catheter. Then again PIC-TEL catheter from Cordis. Then Lehmann ventriculographic catheter and Sohn's catheter, which is tapered tip. So most commonly used catheter is PIC-TEL, and it passes very easily through normal aortic valve, and if we want to cross the stenotic aortic valve, then we need help of a leading guide wire. We should pass the guide wire through the PIC-TEL. It straightens the tip, and then it becomes very easy to cross the stenotic aortic valve. And when patient had previous surgery of aortic valve, and if porcine aortic valve prosthesis was put, then PIC-TEL is the catheter of choice to cross this bioprosthesis, because its configuration allows it to allows the catheter to prevent from sliding down, and so it directly enters into the LV from aorta. And no catheter should be crossed across a tilting disc aortic valve like Medtronic Hall or St. Jude catheter, because it can entrap the catheter. While we pass the catheter, if it passes through the minor orifice of the valve, our catheter can get entrapped. So catheter should not be passed across a tilting disc aortic valve prosthesis. Sohn's catheter is used when catheterization is performed from brachial approach, but nowadays we are mostly using PIC-TEL catheter only. Then NIH and Eppendorf catheter, they have multiple side holes, but they have a closed end. So these two catheters are no end hole catheters, and these NIH catheters are relatively very soft and they are unlikely to cause dissection or perforation. These catheters can gently be prolapsed across the aortic valve, but because they are closed end catheters, we cannot pass the guide wire through it. Lemon catheter has a tapered closed tip and it extends beyond the multiple side holes, and this tapered tip assists the operator in manipulating the catheter through the tortuous arteries, and even if it is very useful while crossing a stenotic aortic valve. Which injection sites to be used when we are doing ventriculography? For the left ventricle, the optimal position for the catheter is mid cavity, provided that it is not producing VPCs. This mid cavitary position, it ensures that the delivery of the contrast material will be adequate to the chamber's body and the apex, and lack of interference with the mitral valve function, because it is in the mid cavity, it will not interfere the mitral valve function, and so it will not falsely produce the mitral valve regurgitation. So if you want to assess the mitral valve regurgitation, then specifically we should put our catheter in the mid cavity. And when we put the catheter in the mid cavity, it automatically positions the hole through which the contrast material is injected. The holes will be adjusted like that they will be away from the ventricular trabeculae. So the complications like staining and perforation will be less likely. In some patients, this mid-cavitary position, it may induce repetitive ventricular premature contractions. So in such case, we should put the catheter in the left ventricular inflow tract, immediately in front of the posterior mitral valve leaflet, and this position, which is in the left ventricular inflow in front of PMVL, it is usually free of ventricular ectopy. But if we want to assess this mitral valve regurgitation, then we should make sure that it should not be very close to the mitral valve, otherwise it will falsely produce mitral valve regurgitation. In right ventricle, the optimal position for the catheter is also mid-cavitary, provided that provided VPCs are not a problem, and if VPCs are uncontrollable, then catheter may be positioned in the outflow tract just below the pulmonary valve. Injection rate and injection volume through the catheter while doing ventriculography, it is very important, because we should deliver adequate amount of the contrast material so that it will opacify the ventricle we want to visualize properly. And there, in the market there are some injectors available which allows the synchronous injection of the contrast material with the R wave of the electrocardiogram, so that the flow rate is delivered during the diastolic period of the cardiac cycle. So it is believed that this technique causes less incidence of VPCs, and also the amount of the contrast volume required to opacify the chamber will be less in synchronized injectors. But still it does not offer clear-cut advantage over non-synchronized method. So while we do the left ventriculography, the injection rate and volume of the contrast, it depends on which catheter we are using, what is the size of the catheter we are using, and also it depends on the size of the ventricular chamber which we are going to visualize, and approximate ventricular stroke volume and the pre-ventriculographic hemodynamics of the patient. Most cases when we do the ventriculogram using pigtail, the standard is to keep volume of 30 to 36 ml, total volume 30 to 36 ml, and it is to be injected at 10 to 12 ml per second, and usually it is a 3-second long injection. When patient's ventricular chamber is larger, or when patient has high cardiac output state with regurgitation, valvular regurgitation, or some high cardiac output state, in those conditions higher volume and rate will be required to opacify the ventricles. And similarly, when patient's ventricular size is smaller, and if patient has irritable ventricles, then smaller volume and rate should be adjusted in those patients. And when we use end-hole catheters like multipurpose catheters or Sohn's catheter, then the rate of the injection should not exceed more than 10 ml per second, and we should keep it at around 10 ml per second to prevent the recoil and to prevent the staining. So the total dose for this per cath, total contrast volume per cath is 5 ml per kg for the patient, and per injection dose is 1 to 1.5 ml per kg as per the conditions, and PSI for the pigtail is maximum 1200 PSI. Usually for ventriculography we keep PSI at around 600 to 800. Filming projections and technique, it is very important because we want to delineate the structure of the interest, and there should not be overlapping with the other structure. So for maximum delineation of the structure of the interest and to prevent the overlapping, this proper technique is very essential. 30-degree RAO projection, it eliminates the overlap between heart and the vertebral column, and so it allows the assessment of the anterior wall of the heart, then apical wall, then inferior segment wall motion, and it also profiles the mitral valve. So it helps in reliable assessment of the presence and severity of the mitral valve regurgitation. That is RAO 30-degree projection. Then LAO 60-degree projection, it allows us to assess the ventricular septal integrity and motion. Then also it helps in evaluation of the lateral wall and the posterior-basal segmental function of the left ventricle and aortic valvular anatomy. To prevent the foreshortening of the left ventricle and to visualize the whole interventricular septum, to visualize the entire length of the interventricular septum, some cranial angulation should be added to LAO projection. And this angiogram, when we are doing with cranial angulation, they should be performed during the deep inspiration so that to minimize the obstruction by the diaphragm. LAO cranial view, it helps in visualizing the entire ventricular septum. So it will help in assessing the ventricular septal defect and associated left to right shunting. And LAO cranial view also helps in hypertrophic obstructive cardiomyopathy for assessment of the SAM of mitral valve, systolic anterior motion of the mitral valve, and also assessment of the septal bulge of the IVS. And if there is any isolated lateral wall motion abnormality, it can be identified with LAO cranial view. Biplane ventriculography, if available, it is a preferable mode over single plane ventriculography, because it gives more information, more qualitative information with no additional risk to the patient. And if the patient has coronary artery disease, then biplane ventriculography is very helpful in locating and in assessing the severity of segmental wall motion abnormalities than does the single plane ventriculography. And if the patient has congenital heart disease, especially if we want to evaluate anatomy of the right ventricular outflow tract and pulmonary valve and proximal portion of the pulmonary artery, biplane ventriculography is superior to single plane ventriculography. There are certain disadvantages of biplane ventriculography also. First is the cost of the equipment. It is expensive. Second is the quality of the image will be somewhat reduced due to the radiation scatter produced by the opposite plane. Third is this equipment is to position this equipment, we need the additional time is required. So it is time consuming process to use this biplane ventriculography, and also it will lead to the additional radiation exposure to the persons inside the room. Common angiographic views used in congenital heart diseases. For VSD, commonly used view is LAO cranial view, in which 60-degree LAO and 20 to 30 degree of the cranial projection is done. For ASD, assessment of atrial septal defect, hepatoclavicular view is the best. It is also known as 4-chamber view, and here 40 to 45 degrees of the LAO and 40 to 45 degree of the cranial angulation is done. For transposition of great arteries, late back angiographic view, steep epicaudal view 35 degree is used, and to assess the proximal branch pulmonary artery anatomy, epicranial view is used. And especially if we want to assess the ostium of the left pulmonary artery in cases of tetralogy of Fallot, then we should add 5 to 10 degrees of LAO to this cranial angulation. It gives us better idea about the ostium of the left pulmonary artery. For assessment of patent ductus arteriosus, the best views are left lateral and RAO views. Ventriculography helps in evaluation of ventricular function. So by doing left ventriculography, we can assess the regional wall motion abnormalities, and we can grade them into normal, hypokinetic, akinetic or dyskinetic. And the segments to be evaluated, which are seen in RAO view and LAO view. So we can assess the segments, and by segment wise we can say whether this segment is contracting normally, or the contraction is hypokinetic, akinetic or dyskinetic. In RAO projection, we can assess the motion of the anterior wall, anterolateral wall, apex, inferior wall and the inferobasal wall, posterobasal wall. And in LAO, we can assess the contractility of the septum, even the integrity of the septum, and wall motion abnormality of the anterolateral wall, lateral wall and the posterolateral and basal. Ventriculography also helps in evaluation of mitral regurgitation, and it helps in evaluating mitral regurgitation by grading the severity. We can grade the severity in RAO view. We can grade them from 1 to 4 grades, and we can see whether there is any systolic leakage of the contrast into the left atrium from left ventricle. So it will opacify the left atrium. If there is regurgitation, even when we are doing the left ventriculography, we can see the contrast opacifying the left atrium as well in case of regurgitation, mitral regurgitation. We can grade mitral regurgitation by using this left ventricular angiography. Sellers and their colleagues have given us the standard gradings. Grade 1 is when there is only minimal mitral valve regurgitation, and when regurgitation clears rapidly from the proximal chamber with each beat. Then grade 2 is a moderate opacification of the proximal chamber, is LA in our case, but it clears with not each beat, but it clears with subsequent beats, so it takes some time. Grade 3 is intense opacification of the left atrium, and this opacification is so intense that the density is almost equal to the left ventricle. So it is grade 3, and we'll see it grade 4 when there is intense opacification of left atrium. It is even denser than the left ventricle, and this opacification persists over the series of the images obtained. So this is how we can grade the mitral regurgitation while doing left ventriculography. Ventriculography is very helpful in ventricular septal defects. There are standard views which are very helpful in delineating the ventricular septal defects. First is this long axial view. It profiles the anterior ventricular septum and left ventricular outflow tract, and to prevent the foreshortening of the left ventricle and to visualize the anterior septum of the interventricular septum, some cranial angulation 15 to 20 degree should be added to the 60 degree LAO view. So majority of the perimembranous VSDs are profiled in this long axial oblique view. Next is the hepatoclavicular view. It is also known as 4-chamber view. It profiles the posteriorly located VSDs and also profiles atrial septum. It separates atrioventricular valves and places the 4 cardiac chamber and phase. And this also clarifies the relationship between mitral valve and semilunar valve and its relationship with the outflow tract. Other is anterior posterior axial, and the other common view required to profile VSD, especially in outflow tract VSD, is right axial oblique, RAO view. Long axis view is best for demonstration of different types of perimembranous defects. Some doubly committed VSDs will be seen on this view, but we cannot demonstrate the lack of infundibular musculature between which separates the hinge point of the leaflets from the defect. So to demonstrate that, right anterior oblique projection is the best view for outflow tract VSD, for doubly committed VSDs. This long axial view is also best for muscular defects in apical trabecular septum, and also some defects which are between the outlets are profiled both in long axial view and right anterior oblique projections. So this is the image which in the image A, we can see the perimembranous VSD opening into the right ventricular inflow tract. In image B, this is left ventriculogram, which is showing perimembranous VSD, which is opening into this this defect is opening into the right ventricular inflow. And in the third image, image C, we can see the defect which is opening into the trabecular cavity of the right ventricle. So these all three are the left ventricular angiogram showing the perimembranous VSD. This is again left ventricular angiogram in long axial view. In the first image, it shows the arrow shows the single defect which is present in the apical trabecular septum, and in the second image we can see the multiple defects in the apical trabecular septum. RAO view displays the anterior portion of the interventricular septum, and anterior muscular ventricular septal defect or the defect which arises from the conus can be seen nicely, as the jet of the contrast will course superiorly into the right ventricular outflow tract in the RAO view. So here we can see doubly committed VSD seen from left ventricular angiogram. Doubly committed VSD is seen. We can see the aortic valve and the pulmonary valves in direct contact with each other. Then next is the image which is done in left lateral view, and this is not LV angiogram. Here it is RV angiogram taken in patient with severe PH for the evaluation of the PH, and we could find that there was some right to left shunt was present, and we can see that that is just below the pulmonary valve and it is opening into the LV. So that is another large outlet VSD which has been Eisenmengerized and caused severe PH and right to left shunt. This is left ventricular injection seen in RAO view, and it shows us the outflow tract VSD. This is outlet muscular VSD. Then comes the 4-chamber view, that is also known as hepatoclavicular view, and here LAO is kept at around 40 degrees, and to it 40 degree cranial angulation is given. It allows the visualization of the inlet portion of the ventricular septum, and so we can assess the AVSDs, then inlet VSDs, and also the posterior ventricular septal defects can be better visualized in this 4-chamber view. And if we want to assess the atrial septum, then this is the best view to assess the atrial septum, 4-chamber view. And if there is presence of left ventricle to RA communication, it will be better seen in this 4-chamber view. This image is taken in 4-chamber view, and it shows the muscular posterior muscular VSD of around 7 mm, and we can see that the first image is before putting a device, and second is after putting a 10 mm Emplatz device. So we can see that there is no flow across the defect now post device closure. So the ventricular septal defects which are best imaged in LAO cranial view are perimembranous and antiomuscular VSDs, and the defects which are best seen in hepatoclavicular views are inlet VSDs and posterior muscular VSDs. And defects best seen in RAO view are anterior septal VSDs and outlet VSDs, doubly committed VSDs. Ventriculography is also, apart from congenital heart disease, left ventriculography is also helpful in HOCM, hypertrophic obstructive cardiomyopathy. Left ventriculography shows hypertrophied ventricle with vigorous ejection in case of HOCM. Papillary muscle will be seen as prominent, and they will be filling the whole most of the LV cavity at the end of the systole. And in patients with apical involvement of HCM, the extensive hypertrophy may result in spade-like configuration of the LV cavity on LV angiogram. And if there is associated SAM, SAM and mitral regurgitation, they can also be assessed along with this in LV angiogram. So usually the septum, it curves towards the right ventricle. Interventricular septum, usually it curves towards the right ventricle, but if the left septal surface is flat or if bulges into the LV cavity, it suggests that there is hypertrophy of the ventricular septum. And if we do the simultaneous ventriculography of right ventricle as well in a cranially angulated view, then we can properly evaluate the interventricular septum. It will give us the objective evidence about the thickness of the interventricular septum if we do the simultaneous right ventriculography along with left ventriculography. So this is image in hypertrophic cardiomyopathy. This is end diastolic image in the RAO view. It looks almost normal. This shows like normal size ventricle, and the shape of the heart is also normal. Then comes the end systolic image. So we can see here that in RAO view, this is DSA was taken, and it shows the prominent papillary muscles projecting into the ventricular cavity. And here the outline of the end diastolic image has been superimposed on the systolic image. And see, the calculated ejection fraction is very high in this patient. It is around 86%. So it shows the vigorous contraction of the myocardium, and it also gives us idea about the thickness of the myocardium in systole. This is again ventriculographic image, left ventriculographic image of the patient with hypertrophic obstructive cardiomyopathy. This is taken in RAO projection, and we can see that there is a large distance between the ventricular cavity and the epicardial coronary. So between the endocardium and the epicardium, it suggests the myocardial thickness during the systole. So it is heavily thickened, and it suggests the hypertrophied myocardium. If we want to evaluate right ventricle and pulmonary arteries, then we should image right ventricle in frontal or lateral views. Then if we give cranial angulation to the frontal views, it will help in delineating the pulmonary artery bifurcation. Interventricular septum is not imaged well from right ventricle, and if we want to assess the integrity of the interventricular septum, then we should take injection from the left side and not from the right side. Right ventricular outflow tract and main pulmonary artery, they take a posterior course from the heart, and if we don't give cranial angulation, we cannot image these structures properly. So cranially angulated frontal view displays the bifurcation of the pulmonary arteries, and if we want to display the infundibulum, left lateral view is the best view for delineation of the infundibular and for the assessment of the infundibulum. And for the bifurcation of the pulmonary artery, best view is the frontal with somewhat cranial angulation. Course of the right pulmonary artery is posterior to the ascending aorta, and it travels then laterally to the right chest, and it stays anterior to the right bronchus. That is why it is also known as epiarterial bronchus, and it is well seen in the frontal view, and almost it gets foreshortened in the lateral view, while for the course of the left pulmonary artery is posteriorly in the chest, anterior to the ascending aorta, over and behind the left bronchus, also known as the hypertrophic bronchus, and its most proximal portion may not be well seen in the frontal or slight lateral, but the distal portion will be seen well in the lateral view. So if we want to see the proximal portion of the left pulmonary artery, we need to give somewhat LAO angulation to the cranial angulation. So it will give us idea about the ostium of the left pulmonary artery. These are the right ventricular angiogram. First one on the left side is right ventricular angiogram in the AP view with somewhat cranial angulation. We can see that there is aneurysm in the right ventricular outflow tract. In the next image, right side on the top shows the right ventricular angiogram taken in the left lateral view. It shows that there is dilated main pulmonary artery, and it is distal, it is somewhat obstructed, main pulmonary artery. And in the last image shows the bifurcation of the pulmonary arteries. This was taken in the caudally angulated view. In arrhythmogenic right ventricular dysplasia, also right ventricular angiography is very helpful. There are some angiographic features of the ARVD which are global and regional motion abnormality will be seen on angiogram, right ventricular angiogram, and some morphological abnormalities of the right ventricle can be seen in ARVD. These morphological abnormalities are like dilatation of the infundibulum, like trabecular hypertrophy or dysphagia with the dip fissures, and some motion abnormalities like there may be some localized akinetic bulges or the dyskinetic bulges and outpouching. Accordion sign is very specific for ARVD. It is frequently seen in carriers of the mutations associated with ARVD. Accordion sign is corrugated pattern of the free RV wall of the outflow tract. So it is corrugated pattern of the free RV wall of the outflow tract, known as accordion sign, and commonly seen in the carriers of the mutations associated with ARVD. So this image shows the how RV looks in AP view. So on the right side there is RA, and after that there is an inflow tract of the RV, and then trabecular portion of the RV, body of the RV, and the outflow tract of the RV is seen superiorly, and then the pulmonary artery on AP view. Let us discuss about the complications of left ventriculography also. The most common complication is arrhythmias. VPCs occur very frequently during ventriculography, and they are usually caused by the mechanical stimulation by the catheter we used for the contrast injections. This can be eliminated. VPCs can be eliminated by repositioning the catheter, as we discussed earlier also, and sometimes short runs of VT can also occur, and usually they disappear when we remove the catheter from the ventricle. But if it persists, then it should be treated with using IV antiarrhythmics like IV amiodarone or IV lignocaine. If needed, then DC, it should be DC-verted immediately if it causes hemodynamic compromise. And very rarely ventricular fibrillation can be induced by improperly grounded power injector. Vesicular block is also, though it is not very common, but it may happen while doing a left ventricular angiography because of the proximity of the anterior vesicle of the left bundle to the LVOT, and it causes transient left anterior vesicular block. And if the patient has underlying RBBB and left posterior vesicular block, then complete heart block may also occur as we advance the catheter into the left ventricle from the left ventricular outflow tract. Though this is very rare complication. Then intramyocardial injection, it is also known as endocardial staining. So to prevent this, proper positioning of the catheter is very essential. So when the deposition of the contrast material happen within the endocardium and myocardium, it usually happens due to the improper positioning of the catheter, and when the side holes are firmly against the endocardium. So small stain which happens, it usually doesn't cause any problem. But if there is a large stain, it may sometimes cause medically refractory ventricular tachycardia and sometimes even ventricular fibrillation. So it is very essential to position the catheter properly in the mid cavity of the ventricle, mid cavity of the left and right ventricle. And if the mid cavitary position produces this ectopics, then we should position the catheter in left ventricular inflow and in right ventricle. If the mid cavitary position produces this premature contractions, then it should be positioned in the right ventricular outflow tract. Other complication is myocardial perforation, and when it happens, it will produce cardiac tamponade, and to treat it, we should immediately do the pericardiocentesis. Other complications are there can happen air embolism and thrombus embolism. So the proper flushing of the catheter before injection is a very important step to prevent this complication. And patient can develop complication of contrast media like allergic complication or CIN on contrast induced nephropathy on follow-up. So these are the complications of ventriculography. That's all. Done. Thank you.